Hello, I'm Dr. Anthony Wheeler, and I'm going to be telling you everything that you need to know about pathology. Do you recognize what's going on in this image? Do you see the lytic punched out lesions? You should consider radiology. We're going to be discussing plasma cell disorders pathology. This is covered in your book. Please make sure you're keeping up, going over all the lectures, doing your reading. Everything that you need to know is contained in this book. It's the main hub, right? If you need more information or updated materials, they are available on the website. Plasma cell disorders, also known as plasma cell dyscrasias. Plasma cell disorders involve plasma cells. And if you're looking at this image to the right, you should be able to point out at least 10 plasma cells. You remember what plasma cells look like with their eccentric nuclei and their perinuclear half, right? You see them? Examples of plasma cell disorders include multiple myeloma, monoclonal gammopathy of undetermined significance, and Waldenstrom macroglobulinemia. Keep in mind that these plasma cell disorders, the neoplastic plasma cells usually stain with CD138, MUM1, kappa, and or lambda, depending on if it's a monoclonal process or a polyclonal process. We'll talk about that a bit more. Do you recognize the plasma cells in this image? Can you point out at least 10? Okay. All right. So multiple myeloma is a malignant proliferation of plasma cells. In this image, we see an abundance of plasma cells. That's way too much. Multiple myeloma requires greater than 10% of the bone marrow cells to be malignant plasma cells, and technically, they need to be symptomatic as well. That's noting some sort of lytic lesion or an abnormal bone growth, right? Multiple myeloma is the most common primary malignancy of bone. The neoplastic plasma cells produce immunoglobulin, and multiple myeloma is associated with high serum levels of interleukin-6. The excess immunoglobulin can be detected using a test called serum protein electrophoresis, resulting in a monoclonal spike or an M spike, most commonly due to monoclonal IgG or IgM. Also note that osteoclasts that have the rank receptor are activated by neoplastic plasma cells and characteristically degrade the bone. Clinical and laboratory findings of multiple myeloma include bone pain with hypercalcemia, lytic punched out lesions like we saw on the skull imaging. Those lytic punched out lesions show up as skeletal lesions on X-ray, especially involving the vertebrae and the skull, but it can be any bone. These patients might experience fractures even after minor trauma, elevated serum protein, increased risk of infections due to improper immunoglobulin production. On the peripheral blood smear, there's classic association of the red blood cells lining up in a rouleaux formation due to increased serum protein, decreasing the charge between the red blood cells. Primary AL amyloidosis, in which kappa-free light chains circulate in serum and deposit in tissues, may occur, and proteinuria due to kappa or lambda-free light chains, depending on the monoclonality, being excreted in the urine as Bence-Jones protein. Monoclonal antibodies of multiple myeloma lack antigenic diversity, and that's why these patients are prone to infections. The most common cause of death in patients with multiple myeloma is infection. Bence-Jones proteins deposit in the kidney tubules, increasing the risk of kidney failure. That makes sense regarding kidney failure being the secondary issue of multiple myeloma. It's noted to be a myeloma kidney or myeloma nephropathy. You recognize what's going on here in this skull image? Ah, okay. See, that's learning. We review here. We're going to make sure you know everything that you need to know. See the punched out lesions? You have multiple myeloma on your differential. Great. Here is an H&E section that the pathologist reviewed. They sent back their report to you because you're on internal medicine or surgery. And it said, many Russell bodies seen, many Dutcher bodies seen. And you're like, what the heck is that? Just keep in mind that when you hear those buzzwords, it's pointing you in the direction of a neoplastic plasma cell process, which is multiple myeloma for all intents and purposes. What are Dutcher bodies? Dutcher bodies are nuclear inclusions in malignant plasma cells. You can see them here. If you look near the top, that pale purplish circle and the blue nucleus, it's a little bit, if you look at the top, go about a little bit down and a little bit to the right, there's a very prominent one right there. Now, what are Russell bodies? Well, Russell bodies are cytoplasmic inclusions. Those massive orange globs circular here, those are Russell bodies in an H&E. There's a very prominent one about 4 or 5 o'clock from center. You see it? Big pink orange circle. And this is just an image hitting home the point that multiple myeloma affects the kidneys when the immunoglobulin chains build up, causing nephropathy, highlighted by the PAS stain showing myelomatous cast. Anyhow, this is a plasmacytoma. Note all of these neoplastic plasma cells. Again, you see all the neoplastic cells with their eccentric nuclei and perinuclear Hoff. If you look really closely, I'm sure you can see it. This is a plasmablast. You can see some plasma cell features and some blast features. This is a baby plasma cell, but it's basically grown. Regarding multiple myeloma, you need to definitely know what a plasma cell looks like, okay? So I'm sure you know at this point. And keep in mind that myeloma cells produce monoclonal proteins of varying types, most commonly immunoglobulins and free light chains, but they don't function properly. That's why patients are at increased risk of infections. Can you point out the neoplastic plasma cells? We're making sure you know what they look like. Okay. In regards to multiple myeloma, there's a cornucopia of tests and methods that can be utilized to work up this condition, such as serum protein electrophoresis, SPEPs, doing biopsies of various tissues, bone marrow biopsies or biopsies of the lesions. That's all this is hinting at. If you want to look at this in detail, you can pause it, feel free. We're going to move on for the sake of brevity. And this is important to know about. Monoclonal gammopathy of undetermined significance. Monoclonal gammopathy of undetermined significance is an increased serum protein with M spike on SPEP. You see that big spike on the right-hand side of the electrophoresis? MGUS is common in the elderly patient. As we can see here, this band that is darker from a patient that has MGUS on SPEP. Approximately 5% of individuals above 70 years old have monoclonal gammopathy of undetermined significance. And 1% of patients with MGUS may go on to develop multiple myeloma each year. Regarding monoclonal gammopathy of undetermined significance, this is a serum immunofixation, electrophoresis of a particular subject that has IgA kappa and IgG lambda. And you know that because imagine that for each layer, if you don't know how to read this, I'll help guide you through it. So ELP, ignore that. For gamma, A, M, kappa, and lambda, those are various columns. And where the blue shows up indicates that that is something in that column, specifically where it is darker. So we have something in the IgG band, one single dark band in the I column, a dark band in the kappa column, and a dark band in the lambda column. Hence, we can say that there is at least an IgA kappa, because they are at the same levels, as well as an IgG lambda, okay? Now let's move on to another plasma cell dyscrasia known as Waldenstrom macroglobulinemia. Waldenstrom macroglobulinemia is B-cell lymphoma with monoclonal IgM production. Clinical features of Waldenstrom macroglobulinemia include lymphadenopathy, increased serum protein with M spike, which is comprised of specifically IgM. Visual deficits may occur, even symptoms related to hyperviscous blood due to the IgM, which are large pentamers, causing serum hyperviscosity, which may precipitate neurologic deficits such as hemorrhage or stroke, and even bleeding due to the viscous serum resulting from the defective platelet aggregation. Acute complications of Waldenstrom macroglobulinemia are treated with plasmapheresis, which is performed by a branch of pathology. Plasmapheresis removes IgM from the serum. Now, here we have lots of information regarding Waldenstrom macroglobulinemia. Keep in mind that this is a B-cell lymphoma that has clonal plasmacytic differentiation. That's why in panel D here, it's CD20 positive for the B cells. And in panel E, it's 138 positive because there's plasmacytoid differentiation. So we have 20 positivity and 138 positivity. Also, if you look at the bottom of the images, M, N, O, and P, you will notice, specifically in O and P, I should say, that there is monoclonality. How can you tell? Well, there's a large population in the kappa region, specifically for N and O. And there's no expression of CD5 or CD10. That's why that large population there is in the bottom left-hand corner. So B-cell lymphoma with clonal plasmacytic differentiation expressing IgM with monoclonality. And for the gunners out there, if you really want to know if this is a definitive Waldenstrom macroglobulinemia, you can do a genetic test for MyD88. And if that is positive, you hit a home run. You made the diagnosis, Waldenstrom macroglobulinemia. You can hang your hat on that one. I'm proud of you. You even remember MyD88. You even remember MyD88. I'll see you next time. I gotta go. You're too much.